friends. I'm Dr. Vikas Kataria. I'm working as a senior intervention cardiologist and head of arrhythmia services at Holy Family Hospital, New Delhi. Today, we are going to speak on a very important and a very new drug called inclisiran. This is a lipid-lowering agent, and is a very, very recent addition to our already available lipid-lowering drugs armamentarium. So in this talk, we will be discussing and learning more about this drug, inclisiran. LDL cholesterol is strongly associated with increased mortality due to atherosclerosis, cardiovascular disease, and increase in heart attacks, strokes, and peripheral arterial disease. And when it comes to Indians, we Indians are even at a higher risk compared to our Western counterparts. We have not only severe cardiovascular disease, severe atherosclerotic disease, but we Indians develop this cardiovascular disease at a much younger age than the Western people. Elevated LDL cholesterol is associated with increased risk of atherosclerotic CVD. And now we have enough evidence that each 1 millimole per liter reduction in LDL, it is associated with 21% reduction in major cardiovascular events. So it's a very, very strong association between LDL and the atherosclerotic risk. Coming to our first question, what is the level? What should be the level for high risk atherosclerotic disease patients? So there are three different guidelines which help us in deciding that. The European, American, and our own Indian guidelines, Lipid Association of India consensus statement. So we'll start with the American guidelines. American guidelines suggest that patients who are at high risk of atherosclerotic disease, their LDL should be less than 55 milligram per deciliter. And the total reduction should be 50% or more than 50% compared to the original baseline value. So for example, if a patient has a starting value of LDL, then our starting value of 180 milligram percent of LDL, then the first target should be to bring it down to 90 or below. And because these are the high risk patients, then another effort should be made. The second target should be from 90, you bring it down to 55 or below. So first target is to bring 50% of the original value, and then second would be to bring it down to less than 55. And similar is the European guidelines. European guidelines also say that the LDL cholesterol should be reduced in high risk patient to less than 55 milligram per deciliter. And they further go on to say that if the patient is very high risk, which means if the patient has had 2 events in last 2 years, then the goal should be even lower. These patients should have a LDL cholesterol of less than 40 milligram per deciliter. So in patients who have had 2 acute coronary syndrome events in last 2 years, then our goal should be to bring down the LDL to 40 milligram or less. And Lipid Association of India guidelines are even more stringent, I would say. For a very high risk patient, the LDL cholesterol should be reduced to 50 milligram or less. And they further categorize these patients into extreme risk. There are few patients who are at extreme risk. The further categories are category A, B, and C. In the category A, extreme risk, the LDL should be 50 milligram as that of high risk group. And the optional target is less than 30. But if the patient belongs to extreme risk category B, the LDL cholesterol should be kept 30 milligram or below. And if the patient belongs to category C, extreme risk, then the LDL reduction should be less than 10 to 15 milligram per deciliter. Now coming to our second question, that how low can we go? Which is the safest limit of lowering down the LDL? So till now, we have not found any significant association between very low level of LDL cholesterol and safety outcomes. So there was a concern that lower LDL may be associated with cognitive dysfunction and other things. But till now, it has been seen that even if the LDL is 10 milligram or below, there has been no significant safety concern. So one can safely reduce it to 10 milligram or lower. So inclisiran is a new drug. It belongs to a class called small interfering RNA molecule. So it's a RNA molecule that interferes with the production of a protein called PCSK9. So PCSK9 is responsible for destruction of LDL receptors, which are present on hepatocytes on the liver surface. So the job of PCSK9 is to destroy LDL receptor. As a result, the LDL levels start to increase in the blood. So inclisiran, on the other hand, it interferes with the production of PCSK9, which ultimately results in increased level of LDL receptors. When LDL receptors are high, they absorb and internalize the LDL cholesterol into the liver. As a result, blood level of LDL comes down. So inclisiran is basically a small interfering RNA molecule which interferes with the original RNA responsible for production of PCSK9. So as of now, the approved indications of inclisiran are: one is the adults with primary hypercholesterolemia, heterozygous familial hypocholesterolemia or non-familial hypocholesterolemia. In both the categories, inclisiran is approved, even for mixed dyslipidemia. For those patients where we are not able to achieve the target value of LDL cholesterol, which we have seen in our first or second slide, what are the targets? So if we are not able to achieve that target, even with maximum dose of statin or non-statin drugs, then the next step is to add inclisiran. And the third category of patients, third indication, is those patients where lipids are not tolerated. So lipids are contraindicated either because of muscle damage or myositis. So in those patients, inclisiran can be given and is strongly indicated. So these are the three categories. Again, patients who are at high cardiovascular risk, whether it's familial hypercholesterolemia or atherosclerotic cardiovascular disease, and those patients who are not controlled with standard lipid-lowering therapy, including statins, ezetimibe, or bempedoic acid. When you have used any of these alone or in combination, and you're not able to reduce the LDL to target level, the next step is to add inclisiran. And the second indication is it is also useful in the treatment of heterozygous familial hypercholesterolemia. 284 milligram. It's injectable therapy, and it has to be given as a subcutaneous injection in the abdomen. The dose recommended is 284 milligram. The dose studies was in the initial Orient trial, 284 milligram to be given subcutaneously on day 1. That has to be followed by a second injection on 3rd month, and then every 6 months. Because it can be given indefinitely. So after the initial 2 doses of day 1 and 3 months, it has to be given every 6 months. So it comes in a syringe form with 1.5 ml of total volume. It has to be given as shown here, the first dose followed by a 3-month dose, the second dose at 3 months, and then every 6 months. So what can we do if the patient forgets or misses a dose? So if a patient misses a dose and the time from the last missed dose is less than 6 months, then you can give the inclisiran injection then and there only, and then follow the original schedule. But if the time lapse is more than 3 months, then you have to restart the whole schedule. That is, start with day 0, day third month, and then every 6 months. And what if the patient is already taking monoclonal antibody, evolocumab, or other drugs for PCSK9 inhibition? In those patients, if you want to shift from monoclonal antibody to siRNA or inclisiran, then you can do it right even immediately after the monoclonal antibody. But if the goal is, because our goal is to maintain the LDL cholesterol at the lower limit, so do it after 2 weeks, because monoclonal antibodies have to be given, the evolocumab has to be given every 2 weeks. So you can give 2 weeks after the last dose of. The patients who, let's come directly to acute coronary syndrome patients. So whenever a patient of acute coronary syndrome comes to us, then according to the latest CSI guidelines, send a lipid profile within 24 hours, start the maximum dose of statin, either 40 milligram of rosuvastatin or 80 of atorvastatin, along with ezetimibe. If we are able to achieve LDL cholesterol less than 55, which is the target recommended for these high-risk category acute coronary syndrome patients, if we are able to achieve, then continue same. If we are not able to achieve LDL cholesterol more than 50, less than 55, which means that if the LDL is still more than 55 at 4 weeks, then add bempedoic acid, because patient is already taking statin and ezetimibe. The next step is add bempedoic acid. If the LDL still remains higher than 55 milligram, then the second step is add inclisiran or PCSK9 inhibitor. The phase 3 clinical trials for inclisiran are Orient 9, 10, and 11. In the Orient 9, patients with familial hypercholesterolemia were included. In Orient 10, patients with atherosclerotic coronary artery disease were included. And in Orient 11, along with atherosclerotic disease, patients who were considered as equivalent of atherosclerotic, they were also included. For example, diabetes. So the combined pool data of this result was published in NEJM. And as we can see, there was a significant reduction, approximately 51% reduction in the LDL cholesterol with inclisiran. So you can see on the left side that after the injection on 90 days, there is close to 50% reduction in the LDL cholesterol level, and it persisted till the injection therapy continued. If we see at the placebo adjusted mean percentage reduction in LDL cholesterol, then in Orient 18 it was 57.2. So it's a huge reduction. It causes a huge reduction in LDL cholesterol levels. In addition to LDL cholesterol level, the LPA, which is again another atherogenic molecule, it also came down by approximately 41%. We know that there are not much options for reducing LPA. So inclisiran is one of the options for reducing LPA molecule, and the reduction again is huge, 41% compared to placebo. Yes, we have. Now we have a data up to 6.8 years of exposure to inclisiran, and the Orient 8 open label extension of Orient 3, 9, 10, 11, we have combined data of more than 3,000 patients, and there has been no safety concern with long-term exposure. Inclisiran, even on long-term, is well tolerated. There is no significant side effects on short-term as well as long-term, because inclisiran acts directly onto cytoplasm of the hepatocytes. It does not go to the nucleus, so there is no risk of carcinogenicity and immunogenicity. So it's completely safe of major side effects. So to look into this, Orient 4 and Victorian 2P are ongoing trials which are looking at the reduction in cardiovascular outcomes by inclisiran, and the results are expected to come in 2026 and 2027 respectively. So while the results of these Orient 4 and Victorian 2P are awaited, a recently published pooled patient level analysis of Orient 9 and 11 was recently published, and there was a significant 26% reduction in the composite major adverse cardiovascular events compared to placebo. So again, although we are awaiting this randomized control trial, but we have a preliminary data that inclisiran causes a 26% reduction in composite of major cardiovascular events. So with this, I would like to stop here and say that it's good to have inclisiran and other PCSK9 inhibitors in our lipid profile treatment portfolio. There are a significant number of patients where we find it difficult to reduce LDL level to target range, despite using maximum tolerated dose of statin, whether it is atorva or rosuvastatin. If you add vampiric acid, ezetimibe, still you're not able to control. So for these kind of patients, for these kind of high risk patients, inclisiran is going to be very, very helpful. Thank you.